Participants can now see my screen. I see. Good. Okay. And yet my advance button is not working. Why is that? Oh, there we go. We'll begin with the land acknowledgement. We respectfully acknowledge the territory in which we gather as the ancestral homelands of the Beothuk and the island of Newfoundland as the ancestral homelands of the Mi'kmaq and Beothuk. We would also like to recognize the Inuit of Nunatsiavut and Nunatuavut and the Innu of Nitassinan and their ancestors as the original people of Labrador. We strive for respectful relationships with all the peoples of this province as we search for collective healing and true reconciliation and honor this beautiful land together. So this study basically examined patient and provider perspectives on the provision of culturally competent and safe care within Eastern Health. We focused on two of our province's marginalized patient populations, the Indigenous and refugee communities of Newfoundland and Labrador. And I have received many comments that there are so many other marginalized communities that are worthy of being having their stories told, and absolutely I agree with that, but we did have to limit the scope of our inquiry. And so therefore we focused just on those two very broadly defined populations. So today I'm actually not going to focus so much on the findings themselves, but because this is an NL support webinar, I'm going to focus on the process of patient-oriented research that we took to arrive at our results and recommendations. So I'm going to describe the method, and I'm going to present an overview of the results and recommendations, but in a way that really highlights the benefits of patient-oriented research. Oh yeah, that image is just to, I find it odd to talk about, to sort of praise an approach that I took. It feels a little bit sort of like self-aggrandizing or whatever, but I really did want to emphasize the benefits of patient-oriented research, so therefore that's what we'll do. This was a collaboration between Eastern Health and the Aboriginal Patient Navigators and First Light, which it was formerly known as the St. John's Friendship Center at the time we began our research, and with the Refugee Health Collaborative and the MunMed Gateway Project, which is itself a collaboration with the Association of New Canadians. And this next slide will just show a breakdown of the collaborators, just to emphasize the scope of the people who were directly members of the research team. Well, what I really want to focus on is the core research team, who were a very fun group of highly motivated and intelligent student researchers. And that's me in the middle, Fern. What I really want to emphasize today is that 3 of these research assistants were themselves members of the populations that were the focus of the research. So looking up at the top of the screen here, Shaquille was manager of the data collection process in general, and he's someone with lived experience as a cultural and linguistic minority newcomer to the province. Ruba was the community embedded research assistant for the refugee aspect of the research. Ruba is a physician from Syria who was a student in community health at the time of the research. She's an Arabic interpreter and refugee patient supporter and advocate, and she was responsible for recruitment and was also interpreter for some of the interviews. Moving to the other side of the screen here, Adriana Pack was key to the Indigenous research side of things. Adriana was recruited to the project by our collaborators at the Friendship Center, where she'd been an active volunteer. And she worked closely with the Aboriginal Patient Navigators at Eastern Health and helped with the recruitment of participants and also with dissemination of results back to the communities. Adriana was a nursing student at MUN at the time of the data collection. And she's a member of the Miawibugek Nation. So part of our strategy for patient-oriented research was that our research assistants who helped with recruitment and data collection and analysis were themselves individuals with lived experience representing the 2 broad communities that were of interest for this study. So this is patient-oriented research, and that's one of the reasons why it actually really made a lot of sense for this project to have it funded by the Newfoundland and Labrador Strategy for Patient-Oriented Research. We describe patients also as knowledge holders, following the language used by CIHR, to reflect the idea that patients aren't just those people who are sick at this point in time, but they can have the lived experience of the patient population. So for us, patients included sick people and family and friends or community members who support patients. That's what makes them knowledge holders. They're inside experts to the experience of being a patient. And our particular strategy for patient-oriented research was that we had knowledge holders as part of the research team and as external advisors to the project, as well as research participants. And we had the knowledge holders involved at all stages of the research, including at design, recruitment, analysis, and dissemination, which is ongoing. This is kind of saying the same thing in a different way. So for us, a strategy for patient-oriented research meant centering the research squarely with the knowledge holders. We met with and listened to the advice of numerous community advisors. These meetings took various forms. We did group presentations followed by discussions. We did one-on-one informal conversations. We had a series of more formal analysis meetings. So the method of engaging with the advisors varied depending on the information or the feedback we were looking for. Sometimes people approached us to give advice, like the Francophone Association, who'd heard about our work and had some advice for us on recruiting within the Francophone communities. So here you just see represented the four ways that we engaged knowledge holders as team collaborators, as research assistants, as community advisors, and then of course as research participants. So in terms of engaging with the participants of research in that sort of more traditional or standard way of thinking about research participants, our method was primarily interview-based. We did do a survey on patient and provider experiences with barriers to accessing care, one for the healthcare providers, one for Indigenous community members, and one for refugee and immigrant patients, which included a French language version. And those results support the more in-depth results we gathered by talking and listening to people. The interviews we held were in-depth and open-ended, kitchen table style conversations. Everyone who participated spoke at length, very openly, and pretty much in all cases, very frankly, about their experiences and their opinions on where the problems are and what needs to change. For First Nations Innu and Mi'kmaq, Inuit, and Southern Inuit patients, we recruited and interviewed 9 patients and patient supporters, most accompanied by a family member or another support person. And as well, 2 of the knowledge users interviewed had the lived experience of being Indigenous patients. One of the interviews was conducted in Inuktitut with an interpreter who was a family member, and the rest were conducted in English. The distribution was fairly even, but we did find that the most vocal and in-depth accounts were those provided by Innu patients. In terms of the refugee and visible minority newcomers, we interviewed 12 immigrant or refugee patients, many accompanied by support persons. And as well, 4 knowledge users who we interviewed were also knowledge holders with lived experience. That group was comprised of individuals who self-identified as a visible minority and or as non-mainstream in their cultural or religious healthcare practices, and considered themselves to be newcomers to Canada. All participants spoke either English, French, or Arabic, which were the languages that Ruba and I could cover. The group primarily included refugees, including government-assisted, privately sponsored, and blended visa office-referred refugees. But it also included 1 economic immigrant who was a student. Recruitment was mainly by word of mouth through our community-embedded research assistants working in collaboration with our community collaborators. We also used snowball sampling, and we had posters circulated on Facebook pages and community websites. The knowledge users that we interviewed included community support workers who held formal roles. So for example, those who work on behalf of government programs, and informal community support workers. So these are individuals who sort of on their own initiative have been involved in refugee or Indigenous patient assistance with accessing healthcare. Of the 14 community support workers, 6 were also knowledge holders. So they were members of one of the other communities, but they are not counted among the knowledge holders. They're only counted here, and in writing, we describe them as being members of both categories. And of course, the healthcare providers that we spoke to included physicians, nurses, and social workers. And we interviewed a few health decision makers who included managers, directors, and VPs. Most of the interviews were conducted in person, but 4 were done by Skype and 1 by phone. Just a bit more on the interviews themselves. Methodologically, our approach is a critical approach, so influenced by post-structuralists like Foucault, and interpretive. So that means we take culture in its relation to power as our focus. This kind of critical interpretive ethnographic approach intentionally looks to reveal tacit power relations and social inequalities in order to disrupt them. So we collected the stories of knowledge users and knowledge holders, and the interviews were transcribed in full. Then we organized our learning into themes, and then we discussed those themes in kitchen table style meetings with our advisors and revised our results based on input from the advisors and other knowledge holders. So in the partnership model that we used, researchers and knowledge holders and knowledge users are understood to have equal authority and legitimacy as the producers of knowledge. So what that meant practically is that the data isn't just contained in the words of the transcripts, it's primarily found in the discussion about the words in the transcripts. So our analysis meetings were recorded as well with permission and transcribed in full. So overall, this is kind of like the Reader's Digest version of the results. On the Indigenous side of things, programming and leadership are seen as stellar, but patients are experiencing a great deal of discrimination and marginalization and racism from staff. And on the refugee side, we see exactly the opposite scenario. There, it's obvious that healthcare providers are trying really, really hard to be culturally competent and to support patients however they can. So the patients, as much as they're really struggling, they feel supported by staff who care. And by contrast, there's been very little offered from Eastern Health in terms of leadership and programming to support culturally competent care. So we'll just start with the Indigenous side of things. I'll just share this quote with you just to get us going. I heard a lady about a month ago got called a savage. It's hurtful, it's hateful, and as I'm sure you know this as well as anybody else, we're outnumbered big time, and they choose their own ways, and that's it. It's almost like we're told, either you shut up or put up, and whether you like it or not, this is how we're going to treat you. So just a bit about the context of healthcare for Indigenous patients at Eastern Health. The Aboriginal patient navigators support the provision of healthcare services to Indigenous patients and clients and residents. So they provide navigation from the time of the patient's arrival in St. John's to the point of their return to their home community. They arrange transportation from the airport to the accommodation. They orient patients and family members to the city and to the healthcare system. They make sure interpretation is available, and they deal with all sorts of concerns. As well, they accompany patients to appointments. They provide support ongoing. They make sure translation is there, and they maintain contact with patients following discharge. And beyond those specific roles and tasks, the APNs are pretty much on a daily basis working hard to raise awareness within the healthcare system about cultural differences in practices and traditions. And they're also involved in shaping policies and programs related to Indigenous health. Just so you're aware, patients traveling from Labrador to St. John's have their travel arrangements made on the Labrador side of things. So that includes arrangements for air travel, accommodation, food vouchers while in St. John's, the cost of transportation while in St. John's. And so those costs are for the patient and potentially one escort when it's required for patient care. Like, for example, if a patient is having surgery, then they would have an escort. And sometimes when required, they would be accompanied by an interpreter whose expenses would be paid. And those costs are borne by the Indigenous governments, either directly or through Health Canada payments. So there are multiple barriers to access to care. We chose to organize them into these categories: logistics of travel from Labrador, communication, cultural differences, experiences of racism and marginalization, and a category that we roughly referred to as settler Indigenous power relations shaping mistrust in the healthcare system. So I'll just touch briefly on some of these just to give you a bit of a feel for some of the barriers. In terms of logistics, the staff lack of awareness of geography and the distance that have to be traveled continues to be a major issue. And it was kind of interesting to me because Cancer Care had done a lot of work to educate healthcare providers through they had a major initiative called the Big Land Project, which was hugely successful and really did, by all accounts, made a huge difference to staff understanding of the geography of Labrador. But it was really clear from the interviews that there's a lot of education still to be done. So these are just two stories. One patient who arrived at the appointment desk and is told, oh yeah, it's been changed. So staff often aren't aware of just how long and tricky a trip from the northeast coast of Labrador, for example, to arriving at the health sciences, how long that might take. It can take even up to a couple of days, depending on how the flights work and the connections. And the second quote refers to the lack of awareness of the needs of patients once they finally arrive. So in this case, a patient had been traveling all day and hadn't eaten for over 8 hours, and this just wasn't taken seriously by the nursing staff. So there are numerous challenges and costs associated with geography, and I won't go into that. These are detailed in a lot more specificity in the report that's available online. In terms of communication, access to interpretation was a challenge. So patients traveling down from Labrador for an appointment or procedure who need an interpreter either has an interpreter travel with them, and normally if that has been arranged in advance, then it's paid for by either Health Canada for the Innu Nation or by Nunatubet government for the Northern Inuit beneficiaries. But for those who don't have an interpreter with them, or for patients in non-planned sort of emergency situations, then the APNs arrange interpretation. So Innu interpretation is provided through First Light and paid for by First Light. And for the Inuit patients, one of the APNs had been acting as interpreter when required. But we found there was a great deal of confusion for patients about whether interpretation is available to them and how to not so much how to access, but whether they have the right to access it. And that was particularly true for Innu patients. And there was a strong misunderstanding amongst Innu patients that they did not have access to interpretation. And in fact, partly that's because there is a lack of ability to access Innu interpretation. So that's something that there was an urgent need to have beefed up, which I'll return to when we talk about the recommendations briefly. But for me, I think one of the biggest challenges with communication that people were highlighting wasn't the need for interpreter as much as the need for doctors to slow down and attend properly to communication with people who aren't highly educated first language English speakers. So here are just two stories. Some of these young people drop out of school when they're like 4 and 5 years old. And the complicated words, like myself, I can't name those pills. I told them, meaning the doctors, if they're not too lazy, look in their files, just look. Many times I get frustrated at them too, because I just told them, I can't bring my medication out. I can't name you my medication because I don't know what they're called. All I know is there's medications, that's all, but I can't name them. Lots of people are like that, I guess. And this second person. My dad is a very low speaker, and when the doctors talk to him, he doesn't understand. So I have to put it in what you call layman terms for him. He wouldn't know what was going on unless I was there. The doctors don't explain themselves. They're just in a rush, get you in, get you out, like, here you go, deal with it. You know what I mean? It's sad. Yeah, they don't, the quicker they get you in, the quicker they get you out. They're happy. But like my father looks at me going, what just happened? My father got as far as grade 3. So I mean, yeah, it's pretty complicated for them. So that was an Inuit woman. And when we talk about cultural differences, really that's in terms of barriers to access to care, around a lack of appreciation on the part of staff that Western colonial medicine is not the only valid approach to healing. So in the Indigenous context, you can't really separate out cultural practices from power relations. Visitor restriction policies were emphasized a lot by patients as being a barrier to effective and appropriate healing. So as this person says, it's only 2 people that can visit, but when someone is really sick, then we need the whole family. We need to stick together and support our patient. And there was an urgent need identified to have an Indigenous healing space for families to rest and where there can be a space for smudging and so on. And I'll return to that with the recommendations. Patients are using traditional healing and not telling healthcare providers because their experience is that they'll be ignored or laughed at. And here's some quotes that show this. Some people are relying on remedies. Like myself, I know from those remedies from my mom when I grew up. No, I wouldn't tell the doctor my remedies. No, the doctors, I don't tell them anything. When I asked to have an elder conduct a ceremony, I was told no, because there's no smoking allowed. I tried to tell them it wasn't smoking, but they still said no. If patients choose an alternate treatment to what our staff recommends, they may be dropped from the service or spoken of in a derisive manner. Patients have told me that they will not tell some staff members about treatment choices they're making because of this concern. This can lead to interactions between treatment choices that could be risking the health of the patient. And this issue is one that also came up on the refugee side of things, where people are simply not telling physicians about the use of alternative treatment modalities. There are many stories of racism and marginalization, way too many to share in this presentation. Here are just 2 stories. I've had multiple experiences of being discriminated against. One time a doctor accused me of being drunk and on drugs when I was sick with a bad flu. We were being discriminated against by a professional doctor saying that my brother couldn't come in every time he drinks and be put on oxygen or life support because the way the doctor was saying, the life support is so expensive. What about the life of my brother? You know what I mean? That to me was discrimination. They don't look at the well-being of an Aboriginal person. They look at us as drunks, assuming that you're lazy. That's the kind of language they use here. To me, the doctor was saying that to my brother. It's powerful. That was hard to swallow. And actually our elder advisor to the project told us that she was at an appointment at Health Sciences and a healthcare professional said to her, "Don't mind me talking, missus, I can talk the leg off an Eskimo." That one I didn't even want to put down in words here. So aside from explicit discrimination, we heard stories of marginalization. Marginalization means the process of social exclusion in which individuals or groups are denied economic, political, or symbolic power and are treated as outsiders. Marginalization can include treating members of another group as if they're not there or as if their opinion doesn't matter. Marginalization is a form of discrimination that can often go unnoticed by those who've never experienced it. And this quote attempts to explain this to me. We could tell right away the doctor's attitude was different toward us. He was speaking to us, but he wouldn't let us speak. When we tried to ask a question, he would just ignore us. He wouldn't listen to us. So I noticed that right away. I tried to ask him a question and he wouldn't even hear me, or he wanted me to shut up or something. And my husband got really, discouraged or felt really bad. And he just wanted to leave the hospital. He didn't want to stay there and stay at that hospital anymore because of how he was being treated. Some patients made reference to the former Aboriginal patient navigator office space, which used to be a tiny, tiny little, almost like a closet with no windows, and really, really difficult to find. And they referred to that as an example of the marginalization of Indigenous patients and peoples in general. And this gentleman had been saying that to me as well. And then he went on to explain marginalization in terms of its range from microaggressions to systemic prioritization of settler norms and values. He spoke for quite some time and at length, but for me, these words were the most powerful. The big blanket, you know, how do you tear the blanket? You can't do it. There's a lot of change to be done, and we don't have Indigenous police officers, that kind of thing. We have social workers whose hands are tied because they got to go by the system. That's the system they've created. We're assumed to be criminals and looked at in all sorts of ways. It's racism by the police, by the government, you know. Well, we have this paper in the system. There's all kinds of words written. If you don't follow, I'll take your kid. It's covered. It's not canvas. It's paper. So he's still describing this blanket. A canvas tent is much stronger now, but their paper is much stronger than that. You know, that's what I'm saying. The health system needs to be changed, and justice has to be well educated with the doctors or judges, or, you know, that's how I could see the system. That's what I meant by blanket, because that's their system. That's their policy. That's their policing. That's their judgment. That's their doctors. So moving along, let's take a look at the refugee side of things. I'll start with this quote. Then the doctor asked me, like, why didn't you bring them, the babies, to the hospital? Because they have a bad situation. And I told him I actually did bring them here 3 times to the emergency and nobody gave me anything. So I was like, have a lot of yelling and screaming with the doctor. You know, I tell them, we bring our children from the war just to protect them. And here they were sick for 3 months and nobody, you know, gave me the right answer. So before we get into the specifics, this was the main context of healthcare for refugee newcomers that we interviewed. The Association for New Canadians plays a pivotal role in the resettlement of government-sponsored refugees, including helping them to access the healthcare system. Since the mid-2000s, family physicians associated with Memorial's Family Practice Unit have worked hand in hand with the ANC and with the Medical Students Gateway program and with the public health nurse. This group of 4 has been largely responsible for the health resettlement of the vast majority of newcomers to the province since the mid-2000s, led by the family physicians and the public health nurse, who have gone absolutely above and beyond in their efforts to advocate for the health of refugee newcomers. So up until very recently, Eastern Health was not very much involved in that process at all. In the last few years, the Refugee Health Clinic at MUN was morphed into an Eastern Health Clinic, now called the Refugee Health Collaborative. It's still primarily a handful of dedicated family physicians who provide basic health care and referrals to specialists for newly arrived refugees. Privately sponsored refugees are supposed to access the healthcare system with the help of their sponsors, who would find them a family doctor, for example. But when that arrangement is ineffective, and it often is, then they also are assisted by this small handful of family physicians. So in terms of the barriers to healthcare that we heard about, we divided them into these 5 key themes: logistical barriers, language, interpretation, cultural differences, discrimination, and mistrust with care, and non-adherence to treatment. There were a number of logistical barriers to accessing care, and these often resulted in missed or late appointments. Things like poor city transit, hospital registration processes that are complicated to figure out even if you do speak English, difficulty finding sites and finding offices once you're on site, patients not being informed about where they're being referred to or why, so that if they do get lost, it's difficult for them, even with an interpreter, to communicate about where they're supposed to go because even they aren't sure. And of course, patients are still receiving letters at home in English and not even knowing that they have an appointment. The physicians who work with the ANC and the Gateway Project have always had trouble finding other family physicians to take on refugee patients. It takes a lot of time and to work across languages and cultures. And one of the main barriers is that physicians are typically paid in a fee-for-service pay structure. So you have situations like moms traveling with their toddlers because one of them needs an appointment, and the doctor won't also at that time do a check back on one of the others or renew a prescription. So this interpreter is mimicking the doctor. I can't see 3 of them together. So I was like, okay, I know that you can't see them together when there's something that's really, let's say, urgent or something, but to renew a prescription, you know, it's nothing. You're not going to examine the patient. And the doctor said, she needs to book another appointment. This physician explains that it's so time-consuming to work with new refugees because of the language barriers and the complex health needs that actually physicians are losing money. It's fee-for-service, you know, it probably costs to see these patients because it takes a huge, you know, it takes an hour for each patient. I mean, it doesn't pay at all if you're a fee-for-service physician. So one physician did this really out of the goodness of her heart, and so did the others, those who are fee-for-service, because they felt it was the right thing to do, but they certainly didn't get paid for it. And the family physicians have been advocating to have other pay structures offered in order to remove this barrier to finding family physicians to work with newcomers. This one is sort of an obvious one, language barriers and the lack of easy access to interpretation. And this was a major issue. And a great deal of our final report includes stories of patient and provider frustrations with basic communication. One of the aspects of this that I want to highlight is related to the telephone interpretation system that Eastern Health uses. At the time that we did these interviews, it was just the tail end of the previous contract that had been employed, which was really ineffective. It was very poor service. So a lot of our stories were shaped by the fact that the service itself was actually really poor quality, but that it's been remedied now because there's a new contract. However, even with the new contract, there's still problems that remain. One thing is that healthcare providers often don't know how to access the system. They don't know about it. They don't know how to access it. And sometimes even if they do know about it, they don't know how to use it and they find it too cumbersome. And the other issue is that the service actually is only available within sort of the hospital sites. So for example, community physicians and pharmacies don't have access to it. And that's where often the major barriers to communication are. And access to in-person interpreters is also often a challenge. Now, normally this runs smoothly. This is arranged through the ANC, excuse me. But at times, sorry, just a minute. That's like having a sore throat or a frog in your throat when you're trying to do a webinar. But when there's one of the rarer languages, or when there's a sudden or unexpected need for interpretation, then this obviously still remains a challenge. We spoke to many interpreters who feel that they actually don't have enough support to deal with some of the ethical dilemmas that emerge from doing interpretation. And there's continues to be a huge problem with physicians who just don't know how to work with interpreters. Okay, why am I not advancing? There we go. And we heard that there's a lack of acknowledgement or appreciation for some of the benefits of interpretation that are more about interpreting, that aren't just about interpreting words. in terms of the roles that an interpreter can play as a culture broker. So in other words, there's a lack of understanding and appreciation for times in which telephone interpretation actually isn't sufficient, even though it might be the most efficient, and that sometimes that interpreter being present can really help with communication and with healing in a way that goes beyond interpreting words. So let me share this quote with you. They have to ask if you're drinking alcohol or if you're having multiple sexual partners. Some clients will think that's not nice. So I go back to the clients and try to reassure them, try to make them aware of the Canadian culture and the questions, and you just need to answer it. But also for the healthcare workers, I felt they're asking the question. They're very nice with the clients, but they were a little bit hesitant. And this other quote also explains that important role of culture broking. The physician wanted to shake hands with her, and I wanted to say to the woman that you can do it, or that's okay, but like I couldn't. Like, it was so embarrassing. She was so embarrassed, and she didn't do anything. So in terms of challenges posed by cultural differences, these challenges happen when physicians or nurses or others don't understand that the Canadian or the Newfoundland way of doing things is not universal. So for example, we heard stories of people saying, take this medication at dinner time. Well, what's dinner time? Is it at noon? Is it at 6? Is it at 8 p.m.? One of the big concerns we heard among Syrian patients and those who provide care to them is the issue of modesty. Most clinicians sort of understand or get the need for draping because it's not that foreign to Canadians. It's similar to how modesty is considered in Canada. It's easy for doctors and nurses to understand, and they really tend to respect the need for appropriate draping, including head coverings, because this was years ago similar to the modesty requirements for Canadian women. But they have trouble with other aspects of modesty, like a male doctor or nurse shaking hands with a woman patient. Many staff either don't know or they don't care about respecting that one. A doctor came and shook her hand, and she was so upset, like she was the whole way upset because he shook her hand. Like, I don't want to shake hands with him. I don't want to shake. And I was like, calm down. That's okay. For patients trying to convey modesty needs, part of the challenge is the power differential, patient to physician, female to male, and newcomer with no political clout to established Newfoundlander. Clinicians also have problems with alternate models of decision-making and alternate ways of imagining consent and autonomy. I loved this story told by, in this case, a very intelligent and poised and confident grad student who'd been prescribed oral contraceptives for a particular medical condition. And she just wanted to discuss it with her father in the tradition of her family and her culture before agreeing to it. And she was completely disrespected by the physician in a kind of a really shocking way. And so the student explains, the doctor was like, if your dad has any questions, and I think he kind of said it sarcastically, it was like, he can give me a call, I'll explain it to him. There are a number of other challenges posed by cultural differences where again, it's really about physicians and nurses not fully appreciating that best practices are culturally shaped, and that means Canadian practices are also culturally shaped and not universal. So what counts as immediate family? How do naming systems work? Child safety practices were an important one, and I heard a couple of stories of parents who were actually accused of child abuse, when in fact, they were not abusing their child. So in this quote in this first box, luckily it was a judge who had global experience who recognized right away that this use of a different method of diapering a child wasn't actually child abuse. Physicians not respecting and not talking about the use of traditional healing practices is again a huge concern. And I just wanted to point out that there's a huge established scholarly literature that's decades old, showing that it's the norm for patients to use alternative healing modalities alongside biomedicine. And it's the standard in Canada's larger cities for physicians to ask patients what other medicines are being used so they can check for drug interactions or for other things that are working well. But here, patients aren't telling physicians about the use of traditional medicines because they're being ignored or dismissed or laughed at. And we heard this over and over again. The one exception that we found was in people referred specifically to cancer care, where there is a great deal more openness to understanding and working with alternative healing modalities. Interestingly, physicians and nurses and other staff, for the most part, really care. They're trying hard to be culturally competent, and they're really worried that they might make a mistake. They're worried about accidentally offending or embarrassing the patients. Here, this nurse explains that the staff are nervous. They're worried about making a mistake and being judged as incompetent. But the more common story was this one, as explained by the social worker. People are really worried that they're going to be inappropriate or insensitive. There's always an enthusiastic bunch that want to learn more and do more. There's an interest in skilling up. There's an interest in becoming aware from a large number of clinical people who are just saying, God, I'd really like to do some of this work I'm really interested in, but I don't feel I know, or I don't want to be insensitive. I don't want to be, stupid about it. Having said that, there is discrimination, of course. And the precariousness of people's status as citizens means it's difficult to stand up for their rights. Many of them are at times feeling purposely ignored or treated badly because they believe healthcare providers know they can't complain. This couple explains that feeling. The husband says it's about feeling like you can't speak up because it's not your home country. The wife says she feels she's being mistreated because she's an outsider. And she says she doesn't care about being mistreated. We're having a very hard time with the wars and running from the dead people. And, we're survivors. So I can survive with this mad look from the nurse. I don't care about this. It doesn't matter. It doesn't bother me at all. For patients, there was very much a feeling that healthcare providers equate being a refugee with being illiterate and incapable. Partly that's related to Canadian physicians and others not appreciating that the silly questions that they're getting from patients, like, can I buy antibiotics over the counter, are not silly in the context of the world's healthcare systems. In most places, you can buy antibiotics over the counter. One participant expressed her frustration at being treated as incapable. I want to tell the doctor, hey, see, we're not still living in tribes and those stuff. We have technology. For many of the participants we spoke with, this is seen as particularly frustrating experience because, in fact, some of the cities around the world that they've lived in as part of their trajectory as refugees fleeing, many of the cities they've been in are far more sophisticated than St. John's, with healthcare systems that are superior to the ones they've encountered in Canada. So many of the patients we spoke to felt marginalized, their opinions about their own health not listened to. They feel like there's an assumption that they're ignorant, even when patients or parents of patients do have a clear idea about what's going on based on their own health experience. And we see that in the second quote here. Oftentimes, most of the family doctors simply say to the patient, no, we don't have that here. It's impossible that you have worms in your belly because we don't have that here. You can't have that type of infection because we don't have that here for years and years. We eradicated that, so it's got to be something else. They don't consider it. They just disregard it. They don't consider the mother and father's diagnosis. They dismiss it as mumbo jumbo. The issue of missed appointments really points to a cultural divide in terms of what constitutes appropriate patient behavior and what constitutes appropriate physician behavior. So patients feel that when they miss an appointment, physicians are treating them like they're uneducated and don't know about or don't care about physicians' busy schedules and a congested healthcare system or their own healthcare. For patients to overcome such hurdles to actually get to a doctor's appointment, only to have the doctor apparently not do anything but take a wait and see approach or refer to a specialist that's going to take several months. For many, it's very unfamiliar and can be very frustrating. So turning now just very briefly to some of the recommendations, which will focus on cultural humility and cultural safety as the path to accessing healthcare. So we organized our recommendations into 5 themes. create an obvious governance and leadership structure, educate healthcare providers. One nurse actually describes the situation as, I'm trying to make this up, I'm flying the plane as we're building it. Carefully consider the vision for refugee patient navigation, provide sufficient and professional interpretation throughout the Eastern Health region. And most important there was that to make the telephone interpretation service more widely available, especially to pharmacy and community physicians. And of course, training providers with how to work with telephone interpreters and in-person interpreters. And provide and promote an organizational culture of cultural safety by emphasizing cultural humility and relations of power. And that's what I really want to focus on in the last couple of minutes here. So the overarching primary problem within Eastern Health with respect to the refugee side of things in particular was a lack of governance and leadership. As one social worker said, it needs to be somebody's baby. So our recommendations on that are have centralized leadership and oversight of a system-wide approach, enable community partners to guide Eastern Health decision-making, recognize and sanction diversity champions and initiatives that are already working hard within the system, evaluate programs and measure success, communicate and coordinate services, and support capacity building. And part of that governance is about promoting an organizational culture of cultural safety, emphasizing cultural humility and relations of power. So specifically, our findings show that Eastern Health needs to reflect on its place in the context of ongoing colonial oppression, support education about and acceptance of traditional healing modalities, notice places of marginalization and create spaces, most notably Indigenous healing spaces. And on that, I will say most urban Canadian health centers have a building, or if not a building, at least a dedicated space for Indigenous families and to accommodate Indigenous healing methods. That's the Canadian standard right now. Create alternatives to the fee-for-service pay structure for physicians. Acknowledge and support opportunity for unpaid informal community volunteers who are currently shouldering a great deal of the burden of accessing healthcare. And most importantly, reverse the order of who holds the knowledge and consider patients as advisors. So I just want to spend a moment on what I mean by emphasizing cultural safety and humility. It's well established in the literature that training and cultural competency alone is insufficient, and that establishing a culture of safety should be the goal. And establishing a culture of safety requires training in cultural humility. Cultural humility requires turning the gaze inward for individual healthcare providers and decision makers, and for the institution as a whole, rather than focusing on the cultures of patients. Currently across Canada, in the wake of social movements such as Idle No More and Black Lives Matter, all public institutions are being called on to turn the gaze inward, to learn and to change. So this is the priority for Eastern Health. And finally, and part of that, to reverse the order of who has the knowledge. Part of cultural humility is doing that. This means engaging patients and other knowledge holders in decision-making at all levels of decision-making. It's patients and their supporters who are the knowledge holders and experts. One of the most striking learning moments that we had in the context of this research was a teaching from the Indigenous elder advisor to the project. And she said, I'm usually just invited in to give an opening prayer. No one has ever asked me for my opinion until now. And I will end it there. Okay. So Catherine, I think we'll be able to, or Julia's back now, will be able to help me to navigate the questions.
Absolutely. So thanks, Dr. Brunger, for that very informative presentation. It's such an important topic. So as I'd mentioned, if anyone has questions, feel free to unmute yourself and ask through your microphone, or you can type a question in the chat box. And of course, if you can't think of a question right now, but one pops into your head later, feel free to email me. I'll put my contact information there, and I can connect you with Dr. Brunger. I'm sure she wouldn't mind that at all.
I will say that the full report is actually available on the, and I should have put the slide up, I just realized, but I didn't do that, on the Center for Bioethics website. So if you just Google MUN Center for Bioethics, you'll get there. You'll see me under faculty, and you just follow through my link, then you'll get to the full report. Some of the stories that people are telling, especially of discrimination and racism, are really they're quite telling. And equally telling are the stories by healthcare providers about the good things that they've been doing behind the scenes, sort of unacknowledged and sometimes unsupported, that where people are really going out of their way to educate themselves and so on to figure out a way to deal with all of this. Mike, you have your hand up, go ahead.
Yes, hi. Excellent presentation. One thing that came to mind to me was that there's a lot of variability within Indigenous communities, whether it's Inuit, Mi'kmaq communities, and how do you handle that within the system, the healthcare system? Because based on my past experience, a lot of these communities won't speak on behalf of another community. And so they say, we're all separate, and we all have our own, I guess, perspectives and opinions and that kind of thing. How do you guys handle that?
So first of all, you guys, I don't think applies to me because I actually don't work for Eastern Health, so I'm a MUN researcher. So how do they, we'll reframe that as how do they handle it? I mean, I guess you could ask as a researcher, how do I handle getting the information? So it's really interesting that there is a huge, I guess controversy might be the right word, might be the wrong word, right now around how Eastern Health's Aboriginal Patient Navigator program functions, because there has been the feeling, and it seems rightly so, that the way that the Aboriginal Patient Navigator program had been imagined and how it's been constructed by Eastern Health has been one that sees the real Indigenous people in need as being the Northern Inuit. And so the Innu, for example, and to a certain extent, the Southern Inuit of Nunatuavut have felt marginalized by the system itself. So, and the story that's most commonly told around that is that the Aboriginal patient navigators have sort of shifted, over the years. And right now, I understand we're in the middle of another shift where one person has left. But for the most part, they've been Inuit speakers, or if members of Inuit communities, rather than somebody who could represent, for example, the Innu Nation. And so then that seemed to be a real challenge. One, from a scholarly perspective, from a sort of an academic or a theoretical perspective, the thing that really intrigues me about all of this is that it's the way that the settler colonizers are imagining indigeneity that then has shaped the system. And that's something that deserves greater scrutiny.
Thank you.
Thanks for that question, Mike. I also noted a good comment from Glenda. This is a great presentation, so informative. It certainly makes one self-reflect and want to increase their knowledge and ways to communicate more effectively. I completely agree.
Thanks,
and just a note to you all that I did paste the link to the Eastern Health Diversity full report in the chat as well.
Oh, thank you.
Kathleen found it for me. Another participant on the webinar.
Well, thanks.
Looks like we have another hand, Christy.
We're not hearing you, Christy.
So Sorry about that. I had the wrong microphone on. Thank you very much for the wonderful presentation. My question is, what are the next steps for your project, and how will you ensure that your learnings are actually included or applied?
Yeah, great question. So we met before this even actually was disseminated to the broader communities. We met with Eastern Health, with the leadership team, with VPs, and discussed the findings and presented our recommendations to them. So they have received those who have the decision-making power have received the report and have received our recommendations. As in terms of follow-up, how do we ensure that something is being done? There is a group. I don't know if group is the right word. Within Eastern Health, there's a diversity steering committee that has been doing work consistently over the last number of years. And part of the issue there is that they're doing really good work, but it's actually one staff person who's doing this sort of off the corner of her desk, and she works in HR. And because her mandate is also HR, that the emphasis tends to be on ensuring, that there's diversity and equity and lack of discrimination among healthcare workers, as opposed to focusing on the patient side of things. But that would be, in their opinion and in my opinion, that's the place to expand and to create change within Eastern Health, is through that committee. The partnership with First Light has been a really strong one, and it's sort of there's a little bit more obvious ways to ensure growth by making sure that collaboration remains strong and is enhanced. So that's not a system that's broken, that's a system that's excellent, but it just requires more resources in terms of training of staff.
Thank you.
So I'll look for any other hands that are raised or any other comments in the chat.
Lori
I
has
see
a question.
Lori there.
Yep, no, I've got a question. Hi, Fern.
Hi.
I'm looking at the wrong, you on a different screen here now. Hold on, now I gotta look at myself. Okay. That was really excellent. And I think a couple of the comments were summed up in terms of distressing sometimes as well to hear some of what comes back when we do that type of research. Do you think is some of the biggest issue here the system? With some of those quotes, when I hear them, what I feel, and I'm not a clinician either, as you, I'm a researcher, is just the lack of humanity and the lack of empathy. And then does it speak to the system and how clinicians are working in a system of either being time constrained, overburdened, overworked? I don't know. I can't speak to the system, as you can't either, in terms of Eastern Health. But some of the comments just speak to a lack of just general respect, whether it doesn't matter who it is.
Yeah. It's
just a person that's that lack of empathy for the person.
Yeah, that's part of it, but I think it's
or
a
is it
small
more,
part of it.
It's a small part, okay.
Yeah, I think that lack of awareness, lack of education, and in a sense, that's the easy thing to deal with, because that's about education. Right? It's education in a way that teaches people to self-reflect and so on. So that there's a really obvious fix to that, and you can be a bit optimistic that as education starts to change, as the School of Nursing and the Faculty of Medicine start to really emphasize this stuff in education, for example, that eventually people will get it, and this will not, stupid comments that are hurtful and racist will no longer be a problem. Fingers crossed. I think we can be a little bit optimistic there. But you mentioned the system, and that's where I mean, aside from systemic racism, which is its own issue, as well, we have a system that absolutely doesn't, for example, provide time for physicians to spend time with patients who don't speak English, or for people with a low level of literacy who require further explanation. So aside from educating staff, sometimes even when they absolutely are very empathetic and caring individuals, perhaps even with a great deal of experience in cross-cultural healthcare, even then, if you've got a bunch of other patients waiting, you know, there's the issues of resource allocation and justice in terms of the next patients to come through the door, then really you're caught between a rock and a hard place, right? So the system has to change, and that system is bigger than Newfoundland and Labrador. Just as systemic racism, as much as we can absolutely identify it as a problem in our province, we can also identify it as a problem in every other province, some more than others. And so these are big issues.
Yeah. So, I mean, I guess, do we have any best practice elsewhere? I mean, are other places doing this in a way that we can learn from them? So, I mean, if it's not the if it's not the empathy issue, like you say, around the education, et cetera, that will hopefully get better over time. And we're not going to change the system overnight. So what can we do? What are just some of the key things we can start doing?
Well, so in standard across Canada in other places is, for example, a greater emphasis in medical schools on cultural competency. We have, you know, Carolyn Sturgis does her stuff with Indigenous health. Jill Allison and Natalie Beausoleil talk about, you know, different ways of understanding gender and sexuality. I do a little bit on within the ethics program on cross-cultural dilemmas that are shaped by different understandings of cultural norms and values and beliefs. But that's pretty piecemeal. And in terms of, for example, education, and I'm just talking faculty of medicine for starters, in terms of education on alternative healing modalities and complementary alternative medicine, John Crellin, who's, you know, a long ago retired historian of medicine, tried for decades to get our university to introduce some really solid training in drugs and different kinds of herbal remedies, for example, that we know patients are using, and it fell on deaf ears. So, you know, this kind of stuff that might have been fringe even 10 years ago is now so standard in terms of medical education that big change has to happen, and it is happening. You know, so for example, we have the new module on Indigenous health that, you know, physicians are required to take, for example, that we just developed. So there are some changes happening, but it's not fast enough. And you know, we do have to really attend to how staff who are observed to be making inappropriate comments or marginalizing patients or being discriminatory, to make sure that these individuals are held to task, are noticed, and not just considered to be like, well, that's, you know, that's just how we do things. Right? And that they're brought to task, and that they're re-educated appropriately, and that the stuff is not just brushed under the carpet. That's a priority.
Yeah, I think that's an issue, absolutely. What about with these modules you're referring to, is there any role play? Are there any? Is that embedded in clinical skills in any way, in terms of, say, you know, the actual consultation, just the, you know, trying to help students in particular learn to navigate these situations where English is impossible or difficult, you know, just so how it's going to work.
Yeah, thanks for mentioning that. In fact, I should have. I'm neglectful by not mentioning this. The clinical skills course has for years now been offering a training in refugee healthcare and in working with interpreters. And in fact, the MunMed Gateway Project, which is, for those of you who aren't familiar with it, is the medical school initiative where medical students are matched with, all newly arrived refugees are matched to a medical student working under the supervision of a family physician, and they take a medical history and learn how to work with an interpreter and so on. That's a voluntary program. That program was started by Pauline Duke in the clinical, by two medical students who approached Pauline Duke, who was a family physician teaching the refugee health morning, and me because I was teaching the stuff through ethics. And so Pauline and I responded to the students' request to create this medical clinic, which has been in operation now since 2005 and has been hugely successful. Although it's recently more morphed into the clinical side of thing rather than the experience with cross-cultural education in a kind of more fulsome way in some senses. And that's another thing that.
I mean, I think like you said, there is some good news stories as well. And I find more and more it's the students that are pushing some of this stuff.
Yeah.
And you'd expect to see that because they're incredibly aware of these issues and open to them, and in fact can be even more educated than we are in some ways because we're learning, but they're coming into it. And I suspect even the students themselves will hopefully start to push this, but the system's got to be receptive too. And it sounds like there's some good things happening, but it's still a long way to go.
Yeah, that's right.
I mean, it's amazing work you've done. It was fantastic.
No, thank you for saying that. I think we'll know when things have really changed when the faces of the physicians match the faces of the patients of the patient population. Right? We're doing in Newfoundland and Labrador. We do pretty well with physicians from around the world, but not as specialists. Not so much as family physicians.
Yes.
And we still have a long ways to go in terms of having Indigenous physicians. Yeah.
Yeah, but we're starting to see some come through the med school. So I mean, I think it's a matter of time before they get out and practice. That's and right. We may start to see something that starts to catch up rather quickly versus very slow steps, baby steps, and it may hopefully start to be a bit more exponential in terms of change. So I mean, fingers crossed. Yeah, it's really interesting. Thank you.
My pleasure.
We have a question in the chat there, Dr. Brunger. How have the main findings been implemented so far?
So far, not at all, because this really is just rolling out now. And again, it would have to be Eastern Health who would be the folks to answer that. I'm not an employee of Eastern Health, so I'm not. I mean, it's possible that there are some things in the works that I'm not aware of.
Any other questions before we clue up? I just have a couple of final slides, so I will share those now, and if they'll give you a chance to think of any last minute questions. So just a reminder, or in case some of you aren't aware of some of our upcoming training sessions. We do offer mostly monthly webinars on a variety of different topics related to patient-oriented research as well as other health-related topics. So some of these sessions we are still waiting to confirm dates. So check back on our Eventbrite page. The link is there on the slide. And you can find all of our past events, slides, recordings, including the recording for today's session on our website, nlsupport.ca, and there's a training page there specifically for all of the webinars and presentations. And as well, just another tiny note that we do have a training program open to anyone who's really interested in patient-oriented research. It could be researchers, patient partners, academics. So as I mentioned, we offer monthly webinars, and to avail of the training program, you need to complete 6 sessions with at least 1 in-person session or in-person workshop. Of course, in the past year and a half, we have not been holding really any in-person workshops. So that there's a caveat to that requirement. If you do want to sign up, you can email nlsupport@mon.ca. And of course, you would have to register for each event on our Eventbrite page. So that brings us to the end. If you do have any questions, as I mentioned, for us or for Dr. Brunger, please feel free to reach out. My email is there on the slide, and I'd be happy to connect you with Dr. Brunger if you have additional questions. I'm just going to close or stop sharing and make sure I haven't missed any other hands raised or questions in the chat. I don't think I have. So with that, again, thank you so much, Dr. Brunger, for joining us today. It's such an informative presentation on such a valuable topic. And with that, I will, we have some thank you at some presentation in the chat there. I'll let everyone go and have a wonderful rest of your day.
Thank you.
Bye.
See you.